that the use of PCT in patients with sepsis was associated to reduce long-term complications. And these long-term complications are pretty much related to the exposure of antibiotics to developing multi-drug resistant pathogens. This is the reason that we included this algorithm that was published recently in the journal Antibiotics. And you can see that in this manuscript, what we did was to integrate what we published over the last few years, not only COVID, but also influenza. We went to a cutoff of 0.3 related to how we are going to de-escalate antibiotics. And please look at this. I think that this is an important matter after the cutoff is clinical practice, clinical integration, clinical decision. So it's not just one biomarker is going to substitute clinical judgment. The third is related to stratification of severity. And I think that we were talking about the problems that we have with infection. And I would like to recap that also when we are looking at community acquired pneumonia as a different scores that we can use. In this case, we are using the CORP score. You can really see that pneumonia is not just an infection in a lung, it's a systemic disease. And this is the problem that we can get when the patient is getting worse. And I think that a part of this major criteria that I mentioned to you, there are some other criteria that we need to integrate. We did a study some years ago that was published in ERJ, and you can see here that we incorporate not only major criteria, as I said to you, the presence of septic shock and invasive mechanical ventilation, but all the minor criteria. And you can see that those that they were hypoxemic and those that they have, multilobar in terms of bilateral damage with interstitial patterns were those that they were more associated to a higher mortality. You can see that these were the two minor criteria that they showed higher performance. So this is the reason that when we are looking for the next step, that could be antibiotic treatment, in this case, we recommend the use of a beta-lactamase inhibitor or third-generation cephalosporin, depending on the settings that you are working. So depending on the resistance that you might have with a strep pneumo, and then the use of a macrolide. And the use of a macrolide is not as an antibiotic, is as a immunomodulator, and the macrolide should be prescribed for 3 to 5 days based on this immunomodulation feature. I think that it's important to also confess that in these guidelines, we have to say conditional recommendation with very low quality of evidence, because the majority of the studies were observational studies. So the evidence came from observational studies with many, many, many patients, but there are no studies, probably because of lacking of funding, in critical care patients. So, and when we are looking of macrolides, one could say, well, probably those that they are, I would say, with more comorbid conditions such as chronic respiratory disease or cardiovascular comorbidity, they could benefit. But you can see in this paper, I have to again highlight that they are non-ICU patients, that macrolide was really associated to a better mortality, to a better survival, less mortality in this subset of patients. And the next question would be which macrolide? And I think that in this which macrolide, in this case, again, this is an indirect information because it's an observational study. You can see that it was associated with the use of clarithromycin in terms of 28-day mortality. So moving to other bacteria, and I think that this is an important matter. This is the case of having Pseudomonas or other Enterobacterales. I think that, yes, we have some guidelines here. You can see that I here summarize in this table the different characteristics of patients that they might develop multi-drug resistant pathogens. But I think that when we are looking at multi-drug resistant pathogens, the most important to me could be this last fourth, that could be the group PES, that is Pseudomonas enterobacterialis manifested by ESBL and MRSA. That is more difficult, but it could change dramatically the use of antibiotics. And I could say that probably we have some scores. This is the use of PES score, that you can do it bedside, and is going to give you at least some guidance in order to detect to these patients that they might not be treated adequately with these first-line antibiotics that I mentioned before. So next, I think that it's important to also consider local epidemiology. In this case, in the seventh question, we highlight previous colonization, as I mentioned before, and these specific factors that I showed you as well before. New antibiotics are coming. We have the possibility of integration of new antibiotics. You can see here in this paper published last year that probably there are two antibiotics that, to me, they are showing a high benefit, that is the use of ceftaroline and ceftobiprole, especially for those that they might have the presence of multi-resistant strep pneumo or MRSA in case of ceftaroline, and in case of other gram-negative agents such as Pseudomonas or Enterobacteriales for the use of ceftobiprole. So finally, few words about coadjuvant treatments. I think that when we are looking at the mortality, even with adequate treatment in community acquired pneumonia with severe presentation, based on that, we need something else. And this is the reason that we can see that the number of papers with corticosteroids have been quite high. This is also something that we need to integrate in our algorithms. And this is the reason that the use, for instance, of corticosteroids and in COVID-19, tocilizumab, could change the way that we can rule out secondary infections. And this is the reason that only PCT was better in order to discriminate secondary infections compared to CRP. And then we can see at the evidence. So here we have a huge number of papers. Many of these, they were observational, not they were randomized control trials. But I think that this is what we published in 2022 in this journal belonging to the European Respiratory Society, that is Respiratory Reviews, that the use of corticosteroids was clear in COVID-19, and we were starting to have data. So this is the reason that we incorporated some analysis in COVID, and this is a very interesting paper from France showing that when you are using a late administration of corticosteroids, the benefit was gone. So probably this is the reason that we need to act quite fast. And when we are looking also at those patients in guidelines, and this is the reason that we had probably one of the most controversial PICO question, that was the addition of corticosteroids in guidelines, because the only guideline that we were seen at before this one, that was the ATS, and they did not recommend the use of corticosteroids. You can see that we had to incorporate the paper from Gian Umberto Meduri, but immediately after the guidelines, that was this paper from the King Cape Cod trial with of 800 patients. So it was the largest to date. So we needed to be sure that in our guidelines that we recommended the use of corticosteroids only in those patients with shock, if that was a good recommendation. So this is the reason that what we did was we did a big meta-analysis, including these two papers that I mentioned before, the paper from Meduri and the paper from the King. And what we can see is that the presence of corticosteroids in the therapy was associated to a better outcome in patients that they were in with septic shock. So I think that this is again, reinforcing that the recommendation that we did in our paper was right. So then going back to what I started, I think that remember and rethink about these 4 moments of antibiotic prescription. I think that we need to reflect this to not only to our junior colleagues, but also some people that we are more senior, to consider how we can integrate this in clinical practice. And just keep in mind these 4 points with all the information that I have given to you. And we are coming towards the end of this lecture. I think that just for the guidelines, I think that I was not deep into details in maybe 2 particular questions. That was the need of the use of high flow that is beneficial, and we have seen an explosion of high flow over the last years, and I think that the papers are manifesting that a high flow, probably with the use of non-invasive mechanical ventilation at the same level, is more beneficial than not using this type of devices. And in patients that they might have aspiration risk factors, probably we don't need to change the current antibiotic treatment. So I think that that could be adequate. So, and again, I have to say that this is just a work that, I had the pleasure to lead this paper, and this huge group of people with huge expertise coming from many, many different fields, not only critical care, but also infectious diseases, clinical microbiology, respiratory fields. So all of this is making the guidelines, in my opinion, probably adequate to be implemented in different fields. And thank you very much. And I could be very happy to get any questions and answers that they can be arising during the lecture. Thank you.
Thank you for the talk that Professor Martin Lochez has given us. All the guidelines that he has mentioned here, we have uploaded it into our resource list. Please look for them in the resource list should you want a copy for yourselves. And please feel free to post your questions into the chat box, and we will address the question accordingly. Thank you. Thank you, Prof, for the very excellent and comprehensive talk. Right, I'll have a few questions for you. So we are wondering as well, is serial utilization of procalcitonin common in where you practice? And how do you deploy serial procalcitonin utilization in CAP and even possibly bacteria-resistant HAP?
Yeah, thank you very much. I think that these are, really important, questions. So how do we use PCT in our clinical settings? Is that we incorporate the PCT within the clinical decision making. And I think that this is something that, I mentioned during my lecture, but I think that also I had the opportunity to highlight again. I think that PCT or any biomarker cannot substitute clinical practice. And I think that they are tools. They are tools that they are helping us. And I think that we should use probably serial PCT. In our case, probably we should start the use of PCT. That is my recommendation as soon as you start antibiotic treatment. Not to make a decision. I think that this is important to also to highlight, not to use PCT to say, I'm going to use this antibiotic or the other. No, I'm going to treat the patient and I'm going to send a PCT as a baseline. And then I'm going to see if I could de-escalate the antibiotics, or even the best de-escalation is to stop them. And then we send a PCT afterwards in order to see that there is no need of continue with antibiotics. Related to your second part of the question, that was the use in potential bacterial resistant HAP, I think that this is probably the key question and the most important one. I think that prolonged use of antibiotics is just only going to incorporate resistance. And this is the reason that when we have a positive culture, a bacterial that is sensitive to the antibiotic that we are using, we need to de-escalate. We are obliged to de-escalate, not to use a broad spectrum antibiotic. And then the use of PCT is going to help us to reduce antibiotic duration. The question is, and this is probably related to patients with HAP, it's very similar to what we said in CAP. So treatment duration in CAP should be restricted to 7 days. Treatment duration in HAP, we were a little bit more flexible to say in between 7 to 10 days. But in CAP, if the patient is doing well, by 7 days, you need to stop the antibiotics. But if you consider that in both CAP and HAP or BAP, you need to continue the antibiotics because there is no adequate treatment response, or we cannot reach clinical stability. In that case, the use of PCT is going to guide us when we are a little bit beyond what is the normal patient. So, and this is the reason that the use of biomarkers in our guidelines for HAP and BAP was encouraged in those patients that they might have not adequate initial treatment, patients that they do develop resistance along the way, patients that they might have a complication such as having a cavitation, having an empyema, not adequate distribution of drugs, and patients that they might be even immunosuppressed when we don't know well which is going to be the optimal duration of antibiotics. So coming back, to a simple answer to your question, incorporate PCT as a tool into clinical practice.
Thank you. Thank you for the very enlightening answers. All right, for my second questions, you have mentioned that PCT can be used to make decisions regarding antibiotic treatment for COVID-19 patients safely. Can you share with us how you have used PCT in this aspect? Maybe like how often do you use PCT in these patients' journey, typically on which days of their COVID-19 to know about their antibiotic treatment decisions?
Okay, so, I think that, I'm glad to answer this question because it matched to something that happened here in Ireland. So I've been using PCT for more than 10 years. And I think that, PCT, especially I'm Spanish, I work in Spain, and I was using PCT in my clinical practice there. So when I came to Ireland, it took me a few years until I could implement PCT in clinical settings. So the problem was that we started to use PCT pretty much at the same time that COVID-19 happened. So the learning curve for other of my colleagues was not as I had before, because I did use for several years. But one of the impressive things is that we could find that we could easily, with a low PCT, stop antibiotics. So at that time, we didn't publish we didn't have the publication of the paper that I showed before from Carbonell and colleagues. She is the leading author of this paper about the cutoff of 0.3. But when we started to see that the levels of PCT were low, we could de-escalate antibiotics safely. That is true that, again, COVID-19 was a complete challenge for everyone, and we didn't know about the rates of co-infection. And this is the reason that if you compare the rate of administration of prolonged antibiotic treatment, and I would say prolonged, that means more than 3 days, because if a patient has a non-bacterial infection is prolonged, we can see that over the months we were more familiar with the use of PCT, and we can easily de-escalate antibiotics. That means stop antibiotics, and we could see that resistance were less common. So because in the beginning we had patients that they were maybe with a third generation cephalosporin, sometimes piperacillin tazobactam because of some particular risk factors, and then the patient developed a new event of fever and deterioration, and we were really don't know because the patient was already on broad spectrum antibiotics. So thanks to PCT, we could stop antibiotics. We could come and back, from there. And then what we discovered is that the administration of antibiotic was much, much less.
Thank you for the answers. It's pretty much like how we practice in Singapore as well during COVID times. All right. And the last question, is there a PCT guided stewardship efforts within your hospital to guide the discontinuation of antibiotics in your facilities as a whole?
Yeah. Okay. So when you are trying to use any particular method, you have like two opportunities. You can do it in a systematic way. That means you are going to use it in a part of an algorithm, or you can use it as, in demand. We are pretty much more like in demand. Okay, we are not getting this as a totally strict rule. So what we do is we integrate PCT in our decision making. That is obviously something that it is up to the clinician in order to incorporate this. And I would like to explain this further, because in the guidelines, what we suggested, and this is probably something that is not new, it's something that we have seen over the last years, that 7 days could be enough for a severe community-acquired chronic pneumonia, probably even less. But the thing is that sometimes we have patients that they are doing well, and that means they have a pneumonia, they receive antibiotics, and by day 7, we can stop them. There is no need of PCT there, because you can really see that everything is fine, no fever, extubated, good gas exchange. But I would say that this is not the common pattern in ICU settings. But then you have another group of patients that they might have a mixed message there. So patients that they are going to be still with high oxygen requirements, but they don't have fever. Sometimes the antibiotics might be still given because white cells might be still elevated because, again, the patient is receiving corticosteroids, and that could increase the... So the use of PCT at that particular patient group is going to be super beneficial. So this is how we use it. So, and when we talk about antibiotic stewardship efforts or team, in ICU, we are the antibiotic stewardship team. I think that my recommendation is there is no better team than yourself when you're trying to integrate antibiotic stewardship. This is the reason that we are a bit far from teams that they are coming to ICU, as it happens in other countries, in order to tell you what to do or what not to do. I think that responsibility from the doctor or the physician that is starting the antibiotic is just to consider when you are going to stop it. I think that that is, in my opinion, the right approach.
Wow, thank you. Thank you for the excellent point made. Totally with you. Well, thank you for for giving us a wonderful lecture and answers to all the questions needed. Thank you so much. And
thank you very much.
For the next round, yes, thank you very much. And for the next round, there will be an episode 4 in 2024. We hope to host it in March to introduce the AACC guidance document on the clinical use of procalcitonin, and we will have Dr. Joshua Hayden. He was Chief of Chemistry, Norton Healthcare in US. This is the end of the BRAHMS PCT APAC Talk Show for this year. We thank you so much for joining us tonight, and we hope to see you again next year. Thank you.
Antibiotics prevent millions of deaths and remain the primary treatment for bacterial infections. It is estimated that 1 in 3 antibiotic prescriptions are unnecessary. Paired with clinical signs and symptoms, Procalcitonin can help to differentiate bacterial infection from other potential causes and aid in decision-making around the initiation and duration of antibiotic therapy. Studies have shown that the use of Brahms PCT reduces the overall antibiotic exposure by up to 74%. The use of procalcitonin is recommended to aid in antibiotic treatment decisions in sepsis and lower respiratory tract infection patients. Brahms PCT helps to prescribe antibiotics rationally and to save their power for future generations. Do you want to learn more about antibiotic stewardship with Procalcitonin? Visit procalcitonin.com.